The Indian Health Service obviously has a lot of training in this area, but they actually have a really interesting expanded function dental assisting program, which we've heard a lot about dental therapy today, but this is not that far off from dental therapy in terms of really giving the dental assistants that work in the federal system education for them to be able to do more than what the states oftentimes allow. And then continuing education, of course. And then at the dentist level, the Arizona School of Dental and Oral and Dental Health has actually done quite a focused effort on recruiting and retaining tribal members from all over the country, but in the Southwest area, and has done a decent job of getting those folks in, supporting them and graduating them, and also providing financial support. And then the Centers for American Indian Alaska Native Health in Colorado have also done a lot of work, more research, but they have a whole Center for Native Oral Health Research there that's been really effective over time. So generally the pipeline, just to sort of sum up, we've got, a real lack of investment in moving students from tribal communities into these types of programs, and also opportunities where more training programs could be developed. So let's talk about the movement that's going on with dental therapy. Dental therapists are primary dental care providers. For those of you who were in the last couple of presentations, you've heard about this. They're part of the dental care team. They don't work independently. They serve children and adults, and they provide clinical and therapeutic care. And globally, the use of dental therapists and their safety and effectiveness have been demonstrated. So although this is comparably new, it's been here for almost 20 years now, but comparably new in the United States compared to other areas, it is a pretty established occupation globally. This is just a timeline of, what has gone on. So in 1920, I think it was in 1920 is when the first dental therapy program was initiated in New Zealand. In the 1960s, Forsyth did an experiment where they trained dental hygienists essentially to do restorative work, which is the difference between the dental therapist and the dental hygienist. And that was very successful, but it was not politically successful. In 2005, dental health aid therapists came to Alaska. They had started a little earlier to get training in New Zealand. Then in 2009, Minnesota passed their state level dental therapy. The Maine authorized in 2014. CODA approved the educational standards in 2015. 2016, Vermont passed a bill, and DHATS started practicing in Washington in the Swinomish area. As well as practicing in Oregon underneath a pilot project. 2018, Arizona Michigan both passed bills. Vermont was awarded a grant from HRSA for program development. 2019 was busy. Connecticut, Idaho, Montana, Nevada, New Mexico all authorized dental therapy. And then the National Partnership for Dental Therapy was formalized, which Brett discussed with you. In 2020, Oregon provided a second pilot project, and then the dental therapy program in Illicellewaet College became accredited, the first program to be accredited. By 2021, 5 states have dental therapists practicing. So remember, 2005 was when the first dental therapist started practicing in Alaska, and in 2021, regardless of the fact that we had over 13 states, only 5 states actually had practicing. And this year's been busy as well. Colorado authorized dental therapy. The HRSA work group strongly recommends federal investments, and I'm going to cover that a lot more later. Skagit Valley College open to enrollment. And then looking forward, future trainings, that should be a 2023, sorry, I missed that, are expected in Arizona, New Mexico, and Vermont. So I mean, after looking at this long timeline, you may wonder why has the movement been slow, or has it been slow? And I think behind these sort of timeline pieces that we see, what you don't see and what our evaluation really focused on was how much community engagement underpinned this movement and how tied it was to tribal self-determination and community health uh, advocacy. The genesis in Alaska was absolutely rooted in tribal self-determination, and through this community-driven initiative, they were able to start to remediate historic oral health inequities and trauma. For tribal nations, the strong focus on developing their own local workforce of dental therapists that are culturally and linguistically tied to the communities they serve shifted the oral health care from something accessible only to a small pool of existing providers to something that was attainable and that they built for themselves. The local economic benefit within these sovereign nations was also stressed by communities as a critical driver. So dental therapy generally garners wide bipartisan support, not something we hear a lot these days, but from groups as varied as from grassroots social justice and community advocates to healthcare organizations and even libertarian free market groups. These advocates' sort of unifying message of health equity has been instrumental to the movement's success over time, and in the face of, unfortunately, sustained resistance from organized dentistry. And I will say, I'll talk a little bit more about the federal support later, but this was a really big thing that happened in the last couple of weeks. From a public health perspective, and I just touched on this, the economic development that dental therapy brings, the ability to do better coordination and have individuals be out in the community who the community knows and trusts, and access to culturally competent care are all really, in addition to just the dental care, really important factors that this movement has built. So this tells you sort of the distribution, and I think Laura talked on this a little earlier about the add-ons and the ways that different states have decided to set up their dental therapy program. And I've got them listed in sort of the order from year authorized from top to bottom. Alaska, Minnesota, Maine, and Washington all started their programs or their authorizations prior to CODA at issuing those education standards. And even though the education standards were issued in 2015, it wasn't until I believe 2020 or 2021, I just had on the timeline that Alaska's Ilisagvik College was actually accredited. So anybody that graduated from any of those programs prior to that doesn't, although the program was accredited now, it was not accredited when they graduate, and that is definitely a problem that needs to be addressed. But you can see that there's a mix of tribal only or CHAP-based programs, state programs. There's some carve outs in some of the states. And then a lot of the states tie it to the CODA requirements. The dental hygiene prerequisite, as you can see how prevalent that is down the line there. Again, this is not necessary. This is an additional barrier, but a lot of states have gone that way. There is nothing in CODA that requires a degree level, like a baccalaureate degree or a master's degree. The only program that requires a master's degree are Minnesota and Maine, and they did that because they didn't have CODA standards, so they sort of felt like that would be a better way. But everything beyond that is not. Setting restrictions, this was about, and then where individuals are currently practicing. In Oregon, they are practicing because they have a pilot, but for the most part, it's just the early adopters that actually have folks out in the field. So this is just a little bit about the CODA education standards. There are 5 domains: institutional effectiveness, education program, faculty and staff, education support services, and health, safety, and patient care. Well, training to become a dentist takes about 8 years. Dental therapists can be successfully trained in 3 academic years that, as we say, when you go over the summer, can be done in 2 years, due to the fact that they provide many fewer procedures than a dentist does. And based on the large body of evidence and the effectiveness of safety, and the 2015 CODA accreditation standards for dental therapy education affirmed this, that the 3-year academic program produces well-trained dental therapists. So while implementation is far from achieved, the sort of in many states, the legal, the organizational, and the education framework within which this occupation will exist are now firmly established. So lots of kinks to work out, but definitely the institutional framework is there. This is from the National Indian Health Board. Brett Weber talked a bit about this before, but gives you a sense of the spread. Really, a lot of the work has been up in the South and Northwest, or Northeast a little bit as well, with the states with the red outlines, sort of the ones that are currently looking to advance dental therapy in their areas. So I put the citation here. We published a paper from the 4-year evaluation called Dental Therapists in the United States, Health Equity Advancing. It's in medical care, and I have the URL here too. If anybody wants it, I'm happy to also send a hard copy or a PDF copy. But what we were really looking at was not just, is dental therapy politically advancing, but how is it tied to health equity? What are the health equity outcomes of bringing dental therapy and dental therapists into communities? And some of the first evidence that we had about this came from Donald Chi and his work with the team up in Alaska to look at the impact of the dental health aid therapy program. And there are 2 big studies that came out. The one on the left is a qualitative program evaluation, where they found that a really high level of acceptance, both from the community as well as the other providers, to the care being provided by the dental therapist. They noted that there's more knowledge in the community now about oral health, so really bringing that oral health literacy up. And then they also believe that access for children has improved, but they still wanted more. So they felt that there's still unmet needs, and that overall the impact has been very positive. The second study is quantitative, and they use Medicaid data to look at the actual outcomes of the care provided by dental health aid therapists since they had been in practice since 2006. The treatment days, the DHAT treatment days, were positively associated with preventive care utilization and negatively associated with extractions. So that's extremely and very high level of evidence using claims data, and that they were not increased with, not associated with any increased treatment under general anesthesia. So I put the PubMed links here, but again, also happy to make these available. These should be public, I believe. So really, in the longest standing implementation of dental therapy, which has been in Alaska, you see this really positive outcomes. From our study, our qualitative study, I find this to be such a telling quote. They say, hope isn't a place where it didn't exist before. I've seen the devastation in those villages, and we now have people who have a good job, have a positive force in their communities, in tribal councils, on school boards. They're role models, helping out the kids that need a safe place to live. This is huge for the communities that we're targeting, providing so many more benefits than I ever imagined. And this was a quote from Alaska tribal member that we spoke with in our research. In Minnesota, things are a little bit different. It is not focused on a particular community. It's really focused more on underserved and low-income communities. And they have essentially have evolved into a dual hygiene therapy role. So their training is longer and they have to get a master's degree. So it's very, very different in terms of the pipeline. Although the actual training is the same, the pipeline is different in Minnesota. Having said that, when they did a study in 2019 looking at the patients served by this population, and it it seemed that 100% of the dental therapists were seeing low income or uninsured population. Over 92% were Minnesota Health, which is Medicaid, or racial minorities, population with disabilities, 75% those who require an interpreter, immigrants, refugees, veterans, and then the uninsured, they're not sure. Um, uh, the dental safety net facilities in Minnesota, so organizations like Children's Dental Services or Apple Tree, and as well as the bigger providers like Health Partner have all really picked up dental therapists into employment, and really been able to expand the care that they give. In this slide, this is a colleague of mine, Hawazan Alani, and she actually used the Behavioral Risk Factor Survey, which is a population-based survey, and was able to look at the implementation over time of dental therapists in Minnesota and actually found a positive population-based impact of access to care for all adults, whether they're white or non-white. Those are the top two. And among low-income adults as well, 12.5% relative change after the policy. And then among low-income adults, a really big impact, 19.8% or 19.8 percentage points change among the white population, but actually no statistical significant change among the minority population. So we're not sure what is driving those, but the fact that we were able to pick up a population level difference from one of these large epidemiology surveys was quite remarkable. This slide is, we call this our scope of practice wheel. This is the website is there at the bottom. We have a couple other of these, one for dental hygiene, as well as one for silver diamide fluoride, which is an effective sort of restorative and preventive measure that can be provided in the community. But you can see, similar to the map, the West and Northeast, a little bit in the Midwest have really across the board started to adopt those with a few gaps. But when we look down in the South, there's not a single state in the South that has this. So still really, really large opportunities for, bringing care from the community to the community. So lastly, so that's a little bit about dental therapy spread and equity. The last thing I'm going to share with you today is a little bit about where the published research is. And this is a work in progress. So this is preliminary data. We should have the final data in about a month, but I just wanted to give you a sense of the quality of the work that has been done, both the quantity and the quality of the work that has been done. Okay. So as I said, with the support of the Arfora Foundation as well as HRSA, we are doing a scoping review of dental therapy in the United States. So scoping review is systematic review. Systematic review is looking at all the studies on one same thing, but they have to all be statistical. And the scoping review really asks the question, how many studies are out there? What kind of studies are they? And how good is the evidence within each of the studies that you're presenting? And so we actually screened over 1,500 studies. The inclusion criteria is that the study has to be about dental therapy. It has to be in the United States since 2004. So there's a whole global literature, and that has been reviewed elsewhere and summarized in detail. So we really wanted to just look at what was going on in the United States. We removed a bunch of duplicates, ended up screening 1,166 studies. We found that 274 were possibly eligible for full text assessment. And then we ended up excluding 158 of those once we started really going into the text, realizing that they were out of scope. So we ended up with 116 studies. So In the last 20 years, we've seen, or 18 years, there have been 116 solid studies of dental therapy in the United States, which is maybe the most ever studied occupation in the history of the world. So where we are currently, we have finished 45 of those studies. We've still got 71. All of the studies have been extracted and the data have been extracted, but the final review is still underway. So I am reminding you, these are very preliminary studies, and this may change when we are done. But to share the findings, what we did is we assigned each paper a primary topic. Most of them have a secondary topic as well. But when you look at the distribution, education and training is the focus of the major 27 or 20, the highest percentage of the reports, which is not surprising considering educators often do research and want to know if this new training program is working. So that's the highest. Second is acceptance, and that's sort of like, what is the similar to what I talked about in the Donald Cheese studies. How well do the communities accept this? How well do other providers accept this, et cetera? Scope of practice came next. The impact on the care deliveries, impact of care delivery system was the next highest, followed by scope of practice. And there's a lot of overlap between those two. There have been a few studies on the economics and finance. Most of those have been in Minnesota. And then health outcomes. In fact, we found 10 studies that actually report the health outcomes based on the implementation of dental therapy. 5 focused on cultural competence and diversity, and then another 8 on quality of care. And the quality of care studies were pretty early on when people were still worried about this, and now we're really moved more towards the impact on communities and health systems and outcomes and finance, those types of things. In terms of the number of studies by location, you can see 19 studies happened in Alaska, 32 in Minnesota, another 10 in the Pacific Northwest. 32 were national in scope, meaning that they weren't looking specifically at one state, maybe across different states. And 23 were focused on actually other states. And usually these are kind of acceptability type studies, looking at, would dentists, there was one study in Maryland about would dentists want to have dental therapists or not, something like that. So we evaluated the research quality using 2 different tools. The first one is called the WEIRD tool, but this is used exclusively for descriptive studies. And we really needed to have a good number of these studies are descriptive. And so we needed to have a tool that would help us evaluate the quality of a descriptive study. The second one is called MEDICAT, and this is for all the other studies, so randomized studies, or not that many of those, but cohort studies, observational studies, qualitative studies, so on and so forth. And so what we did is we have a data extraction, and then we have a quality review, and then the quality review is given a final score. And it kind of goes from, no concerns or very minor concerns, up to minor concerns, to moderate to serious. So this gives us an overview of the sense of the quality of the research that's been done across this 116 studies. And when we break it out, you can see that the vast majority are very no or very minor concerns for both tools. So the blue is the MEDICAT and the red is the WEIRD tool. So some minor concerns, it's pretty normal when you're doing observational studies. There's often, you can't control for bias. You can just sort of report that it's there, et cetera. And very few studies with moderate or serious concerns so far. So overall, we're feeling very positive that the type of studies that are being done and the results in the literature are of good quality. And we will be summarizing those findings when we write the paper up. And I just want to close with a couple important things in terms of, how, okay, I've just given you all this data and information and research, and which is all good and fine. You've gotten information from the last two sessions about context for CHAP and about the policy challenges and the support that you have. But there's a huge amount of interest in this right now, that in the federal level. First, at HRSA, the predoctoral training grants in primary care medicine dentistry, these focus on workforce diversity as well as improving training in underserved communities. And these grants have been shown in several studies to actually really have an impact on where dentists go, who they serve, what kind of communities they're going to train in. So, and the recommendations of this second-ish, this advisory committee on training in primary care medicine and dentistry, is really across the board to open up all of those HRSA funding opportunities to dental therapists. And then the Oral Health Workforce Research Center is also funded by HRSA. That's a co-investigator on that. And we actually have a current project examining the dental workforce needs in tribal communities at the request of HRSA. So a lot of recommendations and potential new investment opportunities from the this pot of money. The second, Indian Health Service, I mean, obviously this is going to be the locus of a lot of these types of services. They both federally fund dental care as direct care or in support of tribal direct services. They have a whole list of initiatives. You can go to their website and see all the different types of things they're doing, as well as doing grants to supporting the grants to the dental support centers, as well as the Native Oral Health Network, which is run right here at your own Southern Plains Tribal Health Board. So a lot of resources and activities there. Also at the federal government, CMS funds dental care through Medicaid and Medicare, mostly through Medicaid because Medicare doesn't really cover dental. We keep trying, but we're not there yet. But in a lot of the states where they're working, dental therapists can bill Medicaid, and continuing to think about making sure that that billing is at parity, both in the public and private sector, I think is going to be an important piece as we continue implementation. And then you heard a lot about the National Partnership for Dental Therapy. I just wanted to note that they're doing a huge amount of work to support the community advocacy to make dental therapy a reality. They have a lot of resources, and this is why I have this little arrow here. They have a dental therapy webinar to actually go over this new report and the federal opportunities for support. So for those of you who are interested in that, I highly recommend. They do very good webinars. And then just a couple more, and then I will close. The HRSA task force that just released these recommendations, they note that they're estimated that we have a shortage of 3,350 general dentists. That will never really get solved because a lot of the shortages are because the area doesn't have enough population to support it. But a lot of it is just really a lack of that dentists don't want to go work in those areas. This leaves about 67 million individuals living in dental shortage areas. They really outline it that they see dental therapy as part of the solution. One part of the solution, it's not the only part of the solution. There are a lot of things that can be done. But they note that in Alaska, dental therapists serve approximately 45,000 people in tribal communities, and that this provides a culturally sensitive career path for Native populations. And they have a very high retention of dental therapists in these communities. Historically, retention of dentists in tribal or Native communities has been very low. And so moving forward, they across the board suggest that HRSA provide funding to support training, to incentivize candidates through scholarships and loan repayment, to increase the number of faculty that train dental therapists, and then to fund longitudinal tracking of these efforts. So this is a really important new federal report that has come out asking for the authorizations to really open up these funding streams. So in conclusion, workforce diversity in all of its forms. So diversity, capacity, flexibility. These are things the Surgeon General has called for since 2020. I mean, 2000. But thinking not just about the racial ethnic diversity, but about the cultural diversity, about geographic diversity, and also about just within the profession diversity. And the default approach is to say, oh, well, minority providers, we need them because they will be the access solution. And I think they're a really critical part, particularly when the gaps are so enormous. But more must be done to address the larger structural inequalities that that sort of perpetuate the current status quo. So really thinking about designing an approach that's rooted in social justice, and that's exactly what dental therapy is. Approach the reform of the delivery model with diversity and inclusion as core values throughout the recruitment, education, and practice pipelines. So I believe there are many evidence-based solutions. Dental therapy is one that would move us towards more parity in oral health policy and practice. But we just need the communities to really continue to advocate for this so that our policymakers listen to the communities and not the scare tactics of some of the opposition. So thank you very much. Here is our contact information at HealthForce and my contact information if you need it. I'm happy to take any questions.
Thanks, Beth. We do have one question in the queue. I'm going to send this to you via message, but I'm also going to read it out loud just so you'll have it. The primary topics you listed through your preliminary findings seem fairly comprehensive. In your opinion, is there a topic missing?
Not, that's a great question. So what we haven't done yet, like I said, it's a work in progress. We look at that quality, and then we look at, we haven't cross-tabbed that yet to say, okay, is there one topic area where the quality tends to be lower than other areas, or one topic area where the quality is consistently high? And so I think once we have that information, when we finish the rest of the studies, we'll have a sense of where there's opportunities for doing better research, perhaps in one of the topic areas. The other thing is, I think there are topics that are not covered that would be important. We need to be much further down the implementation path in order to get to that. So for example, getting education programs up and running has been really difficult because of all these layers. They've got to have local accreditation, they have to CODA, they need to meet certain, whatever the state says, oh, I want to have this be a master's degree, or I want this to be a hygiene. And so it's not as if you could just take the model at Ilsavik College, which is just a dental therapy program, and it's got CODA accreditation, and you could replicate that. Problem is, a lot of the states have put these other unnecessary requirements on, so it becomes very difficult to replicate. So I think from an implementation science perspective, there could be a lot of additional work that's done in looking at, comparing these different programs and, outcomes and so forth, but we don't have the programs yet, so we don't have nothing to really compare. The other thing is getting back to that scope of practice issue. Once some of these states that Minnesota has been a long required dental hygiene either as a prerequisite or now it's kind of combined. So it's hard to disentangle. In the earlier time, they did have dental therapists that didn't also have to be dental assistants, but they're not doing that anymore. So once we get more folks out in different states under some of these different conditions that they have, I think there will be a lot of opportunity to see comparatively satisfaction of the individuals in the profession, satisfaction of the patients, how they're being deployed in delivery systems and how the impacts of those are. But I think a lot of the things that I would want to see on the list that are not there yet is because we can't do it yet. It's just not, we just haven't, there's not enough people. And as I said, we've got maybe less than 200 dental therapists in the country, but I think somewhere around that, I don't know the exact number. and 116 studies, right? Like that's like one study for every 2 dental therapists. That's a lot. So this is you know, we'll see as we go forward. Are there any other questions?
I do not see any other questions in the queue, but well, yes, I do. Here's one more. What about the economic impact of dental therapists in rural communities? Seems like maybe there were 5 studies covering that topic. Think that would really relate to policymakers.
It absolutely would. And I know before, I'm gonna say the mid 2000s, there was a study that was done um, here in California by a health economist who basically just said, okay, let's look at the economics of a regular dental practice, and then let's like put a hypothetical dental therapist in there and see what we can do with it. And, it turned out that you could stay profitable and see Medicaid patients if you had a dental therapist. The American Dental Association kind of freaked out, and it's a mess. But the hypothetical is that, yeah, you could do this. Now, where this is happening is mostly in Minnesota, because in Minnesota is the only place we really have dental therapists working in kind of traditional dental practices. Now, those dental practices have to see a certain threshold of Medicaid patients in order to be able to employ the dental therapist. But that's where most of the economics have come from, as well as you also have to understand that dentists evolving away from small independent practices towards larger group practices. And we do see that in Minnesota as well, particularly with health partners have really integrated dental therapists, as well as Appletree, which is has its own special quirks. But in all of those places, they've been able to integrate the information. There's actually a new study on our Oral Health Workforce Research Center website that looks at Appletree specifically and does talk about the sort of shifting scope. They see that the dental therapists are doing more of the less complicated work and really allowing the dentist to move and do more of the complicated higher scope of practice issues. So yes, the answer is yes, we do need more on the finance. When it comes to rural, it's going to be so contextual. Are you employing them in a mobile van? Are you employing them in a private practice? Are you employing them in a tribal clinic or a federally qualified health center or a rural clinic? I think, there's a lot of opportunity for additional work in this, but we kind of got to get people in the field before we could say much more beyond just like the hypotheticals or the Minnesota context.
Okay, now it does look like that was the last question in the queue. However, we do have a few more minutes. Participants, you can unmute yourself if you feel comfortable asking a question out loud.
Hey, Dr. Mertz, this is Julie. I think I may have asked this in the Q&A too. I couldn't get it, I couldn't type it quick enough, and then it seems to be a delayed. But so what about Alaska tribal communities? Has there been any economic impact studies from that area? I know you said most of them are coming out of Minnesota, but with dental therapy having been implemented in Alaska for several years, I just was wondering if anyone had looked and come out with any information or reflection there.
I don't know the answer to your question off the top of my head. I'll say that the Chi et al. Studies that I mentioned, they do look at Medicaid claims, and so it has to sort of, if Medicaid is paying and there are not enough dentists, you're going to have this like limitation on what Medicaid has to pay because you don't have enough providers to get the service out. So you add a bunch more providers, they're going to provide a lot more services to the individuals who are covered by Medicaid, which is, I think, most of the people in the Alaska Native Tribal Health Consortium where they work. So it's going to be a cost, right? The Medicaid program is going to pay more because they now have increased access to care. Now, having said that, the question is paying for what, right? Are they paying for prevention? Are they, and so the fact that there are fewer, there's more prevention happening and fewer extractions happening is an indication that they're shifting the disease burden away from extractions towards prevention. That should, in the long run, I don't know whether that pays off financially for the Medicaid program, but for the community, it's huge, right? That's what you want. And again, the same at the practice level. That's sort of thinking about the Medicaid level. At the practice level, it depends on how those practices are funded, right? So if you're a travel clinic or a FQHC and you have your prospective payment, per member visit payment, and you have a dentist who you have to pay at this level and a dental therapist who you have to pay at this level, and they can work together, you can do more for the money that you're getting, and you're going to be able to provide more services for that. Whereas if you're in a private practice and it's fee for service, it's really production oriented, and it's going to depend a little bit on what the Medicaid program is going to pay, how you set up your staffing model, what et cetera. That's why some of the larger systems have been able in Minnesota to adopt these, as well as in Alaska, because there's a sort of larger system approach and looking at where there are gaps in the system and how to fill those gaps versus just how do I put this person in my practice and make more money, and do the math that way. So I think the economics is like at many levels, and so you just have to like which one. And so I don't know what specific studies would crosstab with that, but stay tuned. We'll get to it.
All right, anybody else? All right, it looks like maybe no one has any more questions.
All right. Well, thank you so much for inviting me to speak. It's been an absolute pleasure, and I hope the work that I presented was useful as you go forward in your work.
Thank you, Beth, for your presentation this afternoon. Participants, just a reminder, if you will fill out your evaluation for this session, and then you have a couple minutes until the next session begins. So thank you all for joining us today.